All right. So welcome everyone. Thank you so much for making the time to join us for the third and last session in the Women's Health Matters webinar series. We're very excited about the topic we're going to be talking to today. It's perimenopause and menopause. But before we dive into the session itself, DPV Health would start by acknowledging the Wurundjeri people of the Kulin Nations as the traditional custodians of the lands and waters on which our services and sites are located. We pay our respects to elders past and present and extend our deepest regards to all Aboriginal and Torres Strait Islander peoples, including any who may be with us today. Now, again, before we dive into the content of today's session, I would like to start by sharing a few housekeeping rules. Today's webinar will be recorded, and as I've mentioned just a few minutes back, the recordings will be shared publicly on the DPV Health website. We will share it via our social media platforms, and if anyone specifically would like a link to the recordings, we can definitely provide that as well. I request that everyone please keep your microphones off or muted for the entire duration of the webinar, just to minimize disturbance and other noises. Participants can submit questions during the session anytime using the chat feature. You will find it at the top tab of your screen, and we will try and address the questions as we progress through the session, but if we don't get time during the session itself, all questions will be addressed at the end of the session. And I also request that we all please demonstrate mutual respect and avoid any kind of negative comments or criticism during this session. So I'll now take the opportunity to hand over to our very, very capable DPV Health Women's Health Nurses team to do a brief introduction of the Women's Health Service and where we're located.
Hi everyone, my name is Shireen. I'm one of the nurses here at DPV Health. I'm currently acting nurse lead while Gulshan's on leave. It's a pleasure to meet with all of you. And to introduce you to our Women's Health Matters webinar series. Whether you're here as a health professional, a community member, or simply someone eager to learn, we're glad we can help. These sessions are about empowering informed choices, breaking down stigma, and making sure everyone has access to knowledge and the support they deserve. So let's keep the conversation open and make this a safe place for learning and sharing. First, a little bit about DPV Health. DPV Health are a primary care provider operating in the northwest of Melbourne, offering a range of services including allied health, dental, counselling and medical services. One of the services that is operated through our medical clinics is our sexual and reproductive health hubs. We offer a range of services for women, some led by the nurse and others led by our GPs. Some of the nurse-led clinics include sexual health assessments, vaccinations, cervical screening, and implant insertion and removal. In addition to the nurse-led services, the GP's services include STI testing and treatment, pregnancy and fertility support and guidance, and contraception options. These can include things that we're going to speak to you about later today. DPV Health Sexual and Reproductive Health Hubs operate from two of our medical clinics, which are at Broadmeadows and Mill Park. Both clinics are close to train stations, so they are easily accessible by public transport, and there is ample parking on site. We now move on to our sexual health team, which include our amazing GPs, Dr. Jellum at Mill Park and Dr. Christina Port at Broadmeadows. We also have a team of 5 GP registrars that work from our Broadmeadows location and have a special interest in women's health. We also have a nursing team of 8 nurses who have all completed a comprehensive sexual and reproductive health training. Across the team, the GPs and nurses speak 9 different languages. We also have access to interpreter services for our patients as needed to ensure everyone has access to services. Appointments with any of our GPs can be booked over the phone or through our website. Another really important part of our team is our wonderful gynecologist, Dr. Vishali, who is our guest speaker for today. I'll now hand over to Dr. Vishali. Thank you.
Thank you for lovely presentation, and thank you for making this happen. All great team of DPV, Pooja, Bonnie, Laura, and everybody else. And thank you all for attending in great numbers. And what was just said that these sessions and the sessions before this are basically for giving control back to yourself to make you understand. I'm saying you means all of us women to understand that the life, the body, the health belongs to us, and empowering us with through this knowledge which is given through these webinars. So we'll talk about it at the end more about what I exactly mean and how we can do it better in future. But let's talk about menopause for which we are gathered together. Next, please. So before starting the webinar, I need to talk about that this presentation is the information provided to improve general knowledge about the condition, is not an advice or treatment of the condition. And if somebody has the issues or want to go on medication, they need to talk to their GPs. And if needed, need to talk to the gynecologist. We are happy to provide you guys with this service. The major information from this has come from RSCGP, Ransacock and Australian Menopausal Society website. And of course, a lot of other information has come from different informative websites. If you want to have the details, we can provide you those. So next, yeah, thank you. So what is menopause? Like menopause is actually a Greek word. Meno means month and pause is cease. So monthly bleeding stopping of the monthly bleeding. And that's exactly is the menopause. You know, there is nothing else. It is a basically we need to understand it's a normal life event. It's just like how girls grow up and go in puberty, um, and they start having periods. So how we look at it, we don't actually talk about it more, or we don't keep thinking about it in that time or later part of our life. But menopause is associated with a lot of anxiety, a lot of misunderstanding, and a lot of difficulty in accepting it. But we need to first understand that this is a normal life event. It's just like getting gray hair, having some wrinkles on the face. And good part of this age is having less mortgage, better stability in life, better expertise in our profession, having grown children and all those things. So it's just a part of normal life. And I'll be hammering on this again and again because when we accept it as a normal life event, then the whole thing changes, the perception toward it, how to go through it, how to manage it, and how to enjoy it, actually speaking. So the definition of menopause is stopping of the menstrual bleeding for 12 months. And that is it. That's all it is. Okay. The stopping of like anybody who comes um, to a doctor or goes through that, if they are in this age, which I'll talk about what age, and they have had complete absence of their menstrual period for 12 months, then they are menopausal. Okay. So what happens during the menstrual period or when the woman is in reproductive age or when she goes into puberty is that um, the women's egg ovary start working. So the egg gets formed, and at around 2 weeks after the first day of your period, um, around that time it undergoes ovulation, and in next 2 weeks, either woman gets pregnant or if she doesn't get pregnant, she gets her period. So all during this time, there are a couple of different kinds of hormones which are produced. One is called as estrogen, before ovulation, and other is called as progesterone after ovulation before period. Um, if I'm getting, if I'm telling you a lot of complex things, Pooja, please stop me and I can explain to you. Okay. And before, yeah, I had to say this before and I forgot that at any point during the webinar, if you can't see me or hear me properly, please let me know and we can adjust that. So coming back to the menstrual cycle, so the estrogen and progesterone are very important to have regular periods and having the normal periods and also having pregnancies. So what happens is that if woman doesn't fall pregnant after ovulation, then she gets period. And during that time, the inner lining of the uterus, which is prepared for pregnancy, gets shed off. Okay, so and that's why a woman gets period. So in menopause, what happens is that there are no more eggs. So if there are no more eggs, then there are no more hormones. If there are no more hormones, then they don't act on the uterus. And then the inner lining of the uterus doesn't get formed, it doesn't get shed, and that's how the period stops. So what happens that at menopause, there is a complete stopping of the period. But it doesn't happen immediately. It's just like the water in the tank. Okay, the water which supplied to us, there is a water in the tank. So when it is at the end of the tank, like when the water storage is decreasing, the flow of the water goes down and eventually it stops. Exactly same thing happens to the uterus. Okay, this is very, very important to remember that because there are some misunderstanding which I'll talk about in a minute after I say what is normal thing. So having the normal cycle depends on not just one egg. It depends on the whole cohort of the egg, which are multiple. Like they were given to us in the mother's tummy around 200,000. Okay, those are that amount of eggs are given to every girl around that number, and that number keeps on growing down. But those all 200,000 eggs work together and their hormone is also produced. Like when a one egg is undergoing growth and ovulation, rest of the eggs are also doing something. So there is a amount of estrogen which is generated by all the eggs. So when the number of eggs go down, that amount of estrogen goes down, and then there is an irregularity of the period. So what happens before period, before complete stopping of the period? For maybe a couple of years, or some in some women it can be 2 to 4 years that they start getting irregular period. What do I mean by irregular? The periods become infrequent. They last for shorter time and they bleed less amount of blood. So each of this is important that a woman should get lesser period in a year. So if they're getting 12 period in a month, they would start getting maybe 10 or 8, and then they bleed for not 6 days, maybe 4 days. Or if they were bleeding for 4 days, they start bleeding lesser and lesser. And then if they're using a couple of pads or 3 pads in a day, they start having less use of pads. That's how it should happen. So anything which is not like this, if a woman is having more frequent period, if they are bleeding more for longer duration, this is not normal. Okay. Having a heavy periods near menopause, it's not normal and needs to be investigated. So you should be going to the doctor. It's not like that, oh, I'm toward the menopause, I'm going to bleed more. No, it's not like that. So just remember the example which I gave you about the water tank. So this is very important. And we miss out a lot of women who are suffering for years together with a heavy period, they think because they think that they are closer to menopause and they are going to bleed. So please seek assistance with your doctors, talk to them and sort this bleeding out. So it's very important. So let's talk about the age of the menopause. So typical age of menopause in Caucasian women is between 46 to 52 years of age. This is influenced by the menopausal age of mother or a female relatives of a woman from previous generation. So if you are reaching to that age, then it's worth having conversation with your mom or aunt, especially mother's side of female relatives influence the menopausal age. Find out at what age they had menopause, and most likely you will be having menopause around that age. Different ethnicities do have different ages of menopause, so not much difference, but a rule of elderly females in your family influencing the menopausal age is across the board. Okay, whether anybody belongs to Western or Eastern world doesn't matter. So anybody who has menopause before 40 years is called as premature menopause, and under 45 years is called as early menopause. So there are implications having early or premature menopause, and we will discuss that shortly. So as I was saying, it's a natural body function and does not need investigation. For diagnosis of menopause, you don't need to undergo any investigation or blood test. Okay. Diagnosis of early and premature menopause, yes, it needs medical attention. It needs a lot of investigation and proper management. So if anybody is having stopping of the periods, so during perimenopause and after menopause, along with stopping the period, they do have hot flushes, night sweats, vaginal dryness, and decreased desire for sex. So this last bit is because of the discomfort or pain due to vaginal dryness. So not necessary that um, the menopause itself will cause painful sex or decreased desire or decreased libido. What happens is that when vagina is dry, then the insertion or continuation of sexual intercourse get discomfortable. It causes discomfort and cause pain, and or even after sex the woman will have pain, and that painful memory is associated with sex. So one bad sex memory will lead to future bad sex. That is a simple thing. So um, loss of libido should not be associated with menopause. I can tell you that women at the age of 90, 95, 98 can also have a awesome sexual life if they want to. Okay, because a major part of libido is driven by your psyche. Okay, and that's not the topic now, and in future we might talk about it. But once you decide, once you've given up that, I'm not going to have good sex because I've hit menopause, it's going to die off. Okay, so sexual desire is like a small plant inside your house. You need to take care of it. It needs as a small plant inside how it continuously needs proper amount of water, light, sometimes fertilizer. If you don't do that, the plant dies quickly. It's the same thing. So the libido it needs constant attention. It needs caring. It needs to work on it continuously. If you don't work on it, it's going to die off. And then most of the time women say that, I hit the menopause, I lost all the libido. So please don't blame menopause. That's not right. It's sad. Menopause is sad because it's been labeled as having a lot of problems, which it doesn't cause actually. So let's talk about hot flushes. Okay, so hot flushes, why do they happen? So all these things, hot flushes, night sweat, and vaginal dryness, is because of lack of estrogen. Okay, so estrogen is the hormone which the body has gotten used to. Okay, so when estrogen is the body, then all these things happen, like formation and the inner lining formation, and then the potentially bleeding if the progesterone is also formed. So the brain, the particular part of the brain, which I'm not going to mention because there is no use. So, which we call it as a temperature center. Okay, so temperature center is very, very sensitive to estrogen. Okay, so when the estrogen is not there, the brain just says, I don't have estrogen. Okay, so it gets worried, like it gets really get panicked, and then the brain sets the temperature center high up. Okay, and when it is high up, then the whole body starts heating up. Okay, it's the same thing which happens during infections. Okay, the infection causes increase in high temperatures in temperature center, and that causes shivering of the body. Like, that's the same kind of thing. The estrogen sets the temperature center at very high temperature, and then the body senses that, oh, I need to feel hot, and the body feels hot because of that. And then the brain understands that, oh, it was only because of estrogen. And then it lowers the temperature. Brain comes to know that, oh, I don't have any estrogen. It lowers the temperature and the woman sweats. Okay. So this is how the hot flushes happen. So in menopause, when we start investigating or talking to women that how it is affecting, then usually 6 of the hot flushes overnight are known to affect women's sleep and then causing problem. Okay, so hot flushes is the major thing which usually affect the sleep and cause all problem. And then we start looking at that whether this woman needs some treatment or not. Okay, so that's where it is. If I have not clarified the pathophysiology, not pathology, the physiology of menopause, please ask me question and I'll clarify it further. Okay, next slide. Thank you. So most of the symptom usually last for 2 to 5 years. Almost 90 to 95% of women do fall into this category. But again, this also depends on how their moms or aunts went through. Okay. Most of the women don't need treatment. The vaginal dryness can last for lifetime and the topical estrogen can be used, but not necessary. If woman has proper foreplay and if she's all decked up for good sex, then she does get moistness in her vagina, or they can use lubrications in any form. There are a lot of over-the-counter lubrications available, or even a moisturizer which suits to your body can be used as a lubrication. Um, there is a small percentage of women who suffer for longer duration. Next. So as in last couple of, or especially in last webinar, we talked about chronic pain. Whatever affects your quality of life needs attention. And it's the same for menopause. If the hot flushes are too much, if it is keeping you awake for whole night, and if that is affecting your quality of life, you can't just cope with that, then it does need management. And actually, um, I think that we should talk about it in last, but let's talk about it, menopausal hormonal treatment, because I want you to focus about this at the end resort, not as a first resort. So previously we used to call it as HRT, hormonal replacement therapy, because we used to think that we're replacing the same amount of hormone, which are going to give you same amount of effect. But now with the time, whole gynecology society all over the world, we know that we don't do that. So now the name is changed to menopausal hormonal therapy. Basically, menopausal hormonal therapy contains estrogen because estrogen is the cause of all the symptoms, the hot flushes of menopause, and that is usually is given. And depending on the if the woman is having the uterus or not, the progesterone is prescribed because only giving estrogen, what it causes is it causes thickening of the inner lining. Okay. And the thickening of the inner lining, if it is ongoing over the period, can turn into nasty things. Nasty things means I'm talking about abnormal changes in the inner lining of the uterus, which can, if it is not treated, can turn into cancer of the inner lining of the uterus and can cause cancer of the whole uterus. So to prevent that from happening, we have to give progesterone for women who has the uterus. So only taking estrogen is the main treatment for all the symptom of the menopause, which is hot flushes, and the progesterone is just a protective effect on the uterus. So MHT is available in top forms of tablet, vaginal pessary cream, and gel, and IUD as well. Next. When to stop? Okay, this is very, very important. So uh, you need to remember that it's the brain which is causing problem, right? Brain is not overcoming the addiction of estrogen because brain is wanting to have that estrogen and forgetting that I don't have estrogen. The brain forgets the estrogen is not there and it raises the temperature center, and that is causing hot flushes. So we are giving the estrogen to the brain and giving the brain to timing some duration to cope and accept that now I'm not going to have any estrogen. eventually I'm going to use this estrogen until I get ready, and then eventually I'm going to stop worrying about it. So it's actually a band-aid. We are not curing it. It's a normal life event. It's a gray hair. We can't dye our hair permanently. Like, yes, we do dye our hair permanently, but the new growth will be still gray. It's the same thing. We can't treat menopause because there are no more eggs. There is no more estrogen in your body. So it has to be for short duration. Okay. Because whatever we do, whatever the medical field has done, anything, everything we do has got a benefit and risk. Okay. So benefit is only for short duration. If we pass that duration, then there are more risk. Okay, so if you're going to start MHT, it needs to be understood that I'm going to take this MHT for a certain amount of time, and I'm going to see to it that my brain understands that eventually, I'll need to stop it. And when you stop this estrogen, there is a possibility that my brain would still want the estrogen and you will struggle then. Okay, so for definition, for our ANZUCA guideline, for our ONG college guidelines, is that you should not start MHT after age of 60, and it should be started within the 10 years of reaching menopause, because um, most of the women have menopausal symptoms for 2 to 4 years. Around 3 to 4% of women do have it for 10 years. So anybody who has hit the menopause at the age of 50 or 52, they should get over it by 10 years. Okay, and then should not be starting on MHT. And it should not be taken indefinitely. It's so important. I think I should have put it in a bold and capital letters. The duration varies from time to time, but side effects start creeping up after 3 years of using the menopause. The contraindication of menopausal hormonal therapy is history of breast cancer. It's absolutely a contraindication. Women who have had breast cancer and some cancers of ovaries and uterus should not be taking MHT. Okay, certain kind of liver disease, because estrogen and progesterone get metabolized, like washed out from the body from the liver. So anybody who has liver disease should be really mindful of taking MHT. High uncontrolled blood pressure. Again, the estrogen is known to increase the blood pressure. Same with any heart problem, myocardial infarction. They should be really like any ischemic heart disease. Like what I say is think when I say ischemic heart disease, is like a heart attack and all those condition or strokes, should be really careful. Or those who have had blood clots in their legs, like a TVT or pulmonary embolism, should not be taking them. And any abnormal vaginal bleeding should not be taking MHT, because we need to find out whether it is something nasty going on the inner lining or on the cervix or in the ovaries as well. So I was talking about the risk and the benefit. So the benefit of taking MHT is not having hot flushes, okay? And the risk of MHT is anybody who's taking estrogen and progesterone, they are at the risk of having blood clots in the legs, okay? Anybody who has blood clots in the legs, the clots can go into the lungs, and it can cause a life-threatening condition or a stroke or heart attack, or affecting other organs as well. Um, so those women, especially those women who are not physically active, or women who are traveling for a long time, like, going overseas or going for a long drive, and if they are on MHT, they should be really careful, because they are at more risk of having blood clots in their legs. And as I said, that yes, the strokes can happen. There is increased risk of endometrial cancer if estrogen is not given, which we talked about. And after 5 years of MHT, then there is an increased risk of breast cancer. Okay. And this risk is not only seen if only estrogen is given. Like if progesterone can cause more increase in the breast cancer. So this is the slide I should have put before we started talking about MHT. What else works and what else keeps working, and which is not without the risk. Okay. So let me talk about the hot flashes, as I was saying, that I get a lot of referral, or I'm sure that a lot of my GP colleagues get patients who say that, oh, since I have reached menopause, I feel sad, I feel depressed, I feel I'm not important, I can't enjoy my life, my skin is getting dry, my muscles are out of whack, whole body feels like it's falling apart. Okay, so all these symptoms basically, it's not only because of menopause. Okay, menopause causes lack of sleep, okay, to some extent. And when there is a lack of sleep, then there is evidence that it causes anxiety, depression. But it's not just that. Okay, so what age the menopause happens? It happens in between 45 to 52. What happens at that age of the woman? Okay, so at that age of woman starts getting some free time, okay, for herself, which she's not used to. Okay, so her children are grown up, they have left the house. Okay, because the woman was busy with her house, her children, her job, she did not have any time for herself. She has not done anything for herself. Like she doesn't have her hobbies. She doesn't have her routine to look after her body. Now children are gone. She's become quite professional or expert in her field. So things come easy at work. So she starts getting more time. Okay, she has less mortgage to pay, so less things to worry about. So suddenly, all of a suddenly, she has got emptiness syndrome and she has got a lot of time at her hand, and the marriage or long-term relation has become stale. You know, she has not worked on it. So all of a sudden, she realized that maybe I'm not important. Okay. Why does that happen actually? It happens because you have not looked after, or you have not got opportunity to look after yourself for a long time. And now you have got a lot of free times and you don't have much to worry about. So then you start focusing yourself, and the main focus comes to the body and the free time. And then we realize that, oh, I'm not as fit as before. My sexual life sucks. And basically, we are at the core reason for that. Okay. So, what helps? What helps? What helps is try to focus on us again. We can do this better. We have looked after our family, we have looked after our children, we have looked after our profession, our relationship, our parents, and we have done much better in that aspect. What have we not done better is our life and our body. So if we could do that to others, we could do that to us, right? So muscle strengthening exercises, very important. Okay, so you need to be disciplined. You need to focus on your body and your mind. So what you could do for your body is that doing some cardio exercises, ideally around 45 minutes of vigorous exercises, 5 to 6 days a week. That's my goal. You can start with 10 minutes. Okay, muscle strengthening exercises at least for half an hour, at least 3 days a week. Okay, and every day some meditation. That will take away 2 hours of a day. If you do that, then you'll not have time to worry about this. And what it causes is estrogen is produced by ovaries, okay, and it has got this all feel good effect basically on your vagina and uterus, and to some extent to our skin. Okay, but when you do vigorous exercises, what is formed in your body is endorphin hormone. Okay, and when you are taking more active role in developing a good relationship, physical sexual relationship with your partner, that produces oxytocin. Okay, both these hormones, estrogen, endorphin and oxytocin, they work exactly as estrogen or better, because estrogen has effect only on the reproductive organ, to some extent on the skin. Okay, but endorphin and oxytocin has got effect in on the all organs, all musculature, on your hair, on your skin. I can't stop talking about it. Okay, and how much dose you want? It's up to you. More you exercise, more you interact with your partner, more estrogen, more endorphin, and more oxytocin you're going to have in your body, and that is going to make you feel good. It's like alcohol, but without any side effect. How much ever amount of endorphin and how much ever amount of oxytocin you have, they are not going to cause any nasty changes in any of your body, but it is going to make you feel good, and it's going to make all your organ behave well without having any nasty changes. You will have better bone health. You will have very good functioning heart, kidneys, your eyes, and your skin. So I would suggest that you should really look into that before even you think about MHT. Okay. As we grow old, this applies to boys as well. Okay. Our bones need to be strong. Okay. Yes, the estrogen has got one good side effect. It's a side effect because that's not the indication for having menopausal hormonal therapy. Having the poor bone health is not the indication. Okay, the only indication for MHT is hot flushes, as I said before. But for better bone health, estrogen helps. As soon as the estrogen is stopped, then the bone health goes down. But eventually, you would need to do that. What helps is doing a muscle strengthening exercises and having a calcium and vitamin D supplement, which every woman should start taking it from the age of 40, around 100 milligram of calcium every day. And depending on where you live, vitamin D supplement. Once you hit menopause, all the women should take 1 gram of calcium and 1,000 international unit for vitamin D if they are low in vitamin D. Okay. Keep working on your libido. As I said, it's totally in your hand. Okay. Not having good libido, don't accept it. It's 100% success. I can guarantee you. Okay. I can guarantee you if you start working today, every day is success. Okay. Use lubricant, whatever your body is happy with, which is the cheapest available. You don't have to spend more. Evening primrose oil can help, can take, soften the age of the menopause. It's known to help your hot flushes if you're really not coping with that. Those women who can't take MHT and they do have to take MHT, then there are other medication. Talk to your GPs, okay? Some of the antidepressant, some of the painkillers like pregabalin, or some of the anti-anxiety medication, which don't have side effect, nasty side effect of estrogen, can help, okay? Seeing a psychologist, working on your brain and telling your brain off that, hey, buddy, we don't have any estrogen anymore. Come back. Okay. We're okay without estrogen. Okay. And that is the change of thinking. Okay. The way do you change the thinking of your brain can be learned by cognitive behavioral therapy, which can be taught by psychologists. So if you're going through bad menopausal side effects, then you should talk to your GP. They'll do you a mental health plan. It's a valid reason. Okay, and you will get 20 free visits per year to see your psychologist. Okay, so I think I passed my timid limit of half an hour to 40 minutes as usual. Or if you have any question, I'm more than happy to answer them. So yeah, these are the websites, like each of them, like Better Health Channel, Gene Health, Royal Women's Hospital, Menopausal Hormonal Therapy. They are the awesomest resources for you to read further about what you can do and how can you make it better without suffering much.
Thank you so much, Dr. Vaishali. That was a very interesting and informative session. And yeah, I'm sure people will have questions from this session. So let's see. We already have one question in the chat. Yeah. What is the average age of menopause for other ethnicities? And how do you tell what's perimenopause and what's polycystic ovaries?
Right. So age, usually it is still, I would stick around to this, okay, after 45, around 50 years, okay. It's not very common to not to have menopause after 52 years of age, wherever you are from, okay. So if you are having a heavy period after age of 52, 53, consult a doctor. There is no harm going and seeking the support, seeing your GP, getting the one ultrasound scan done. If your GP is concerned, then seeing one of the gynecologists is not a bad idea. Now, polycystic ovarian syndrome. Okay, so what happens in polycystic ovarian syndrome? We didn't talk about that, isn't it? Yeah, maybe next Women's Week we'll talk about it. So, in polycystic ovarian syndrome, instead of one egg getting formed, multiple eggs start getting start growing, and they cause increase in estrogen, and they don't ovulate. So there is no progesterone. Okay, so there is a lot of estrogen. So yes, the women don't get period, okay? But when they get period, the periods are longer and they bleed heavy. And then they do have other side effect like having chin hair growth, and increase in weight and difficulty in forming pregnant. So what happens in menopause? It decreases in its amount of eggs. Okay, so I made it clear that women should have less frequent period, less duration, and less bleeding. So polycystic ovarian syndrome also causes a less frequent period, but as I said, that the age group is different. So usually PCOS can happen uh, latest until 45 years of age. Okay, after that the number of eggs start reducing. So the difference is same. So anybody who has polycystic ovarian syndrome, but they still keep having heavy periods, then that is the time that you get investigated, go to your doctor, and they'll do just one scan to find out whether your ovaries are still polycystic or whether they are looking normal. And then they'll look at the inner lining thickness. If the inner lining is thin, that means you are menopausal. And if it is thick, you're still you are having PCOS, which is not well managed. Okay. Did I answer that to some extent? Because it's a huge topic, it's very hard to talk about it in a few minutes. So, yeah, I didn't get that question. Pooja?
There is another
I have another
question.
question.
Sorry.
Can I ask a questions?
Yeah.
Is a man
Pooja.
suffering like lady from these things? And what the symptom we can see it on men when he got this age?
Okay, so men has menopause as well, and the age is totally different. Usually, they hit stopping of their sexual hormone production at around 70, 70 to 75, and some of them do get hot flushes, but they don't talk about it. They don't seek the treatment as well because especially now I'll give you an example. Those who are undergoing chemotherapy or uh, like a chemical castration for prostate cancer or testicular cancer, they do suffer from hot flushes a lot, okay, because their hormones were too high that time. So same thing happens with the men, but their hormonal um, like weaning off is a bit gentler. And for years together, nobody has talked about it. If men start talking about it, I wouldn't be surprised because yes, they do also have hot flushes when they go through the menopause. Okay. But I think they have enough other things to talk about. So let's not, I hope that they don't start talking about it because they'll be having more testosterone support. It's another problem for GPs.
Thank you.
There are two questions, Dr. Vaishali, in the chat.
Mhm.
One is from
Mhm.
Connie Webb. She says, I had a hysterectomy at 46 and started HRT. I was advised I would need to take it till my body would have naturally gone into menopause. How do I know when that would have happened? How long should I take the HRT for?
Yeah. So, Connie, it's a good question. So, I don't know whether you had your like I don't know whether how comfortable you are with talking about your personal health here. But women who have had hysterectomy and their ovaries are removed, then doctors do give the option of going on MHT because it's a sudden stopping of the hormones inside your body, and sometimes that can affect your bone health very badly. So usually the menopausal age is around 46 to 52. So we take it average. So usually we continue the MHT till the age of 50. And then depending on your and your gynecologist or your GP's liking, either they are abruptly stopped or they are weaned off. Okay. So after 50, and as I said before, after 3 years, maximum 3 to 4 years, you wouldn't want to continue them because of the increase in the risk of side effects. Okay, so if you started at 46, I would say that at 50 you should consider, or at 49 you consider, and then wean them off and decide which way you want to go.
Hi, Doctor. This is Connie here. I'm happy to have a chat if you want to ask me anything else.
No, I think are you happy with my answer, or do you want me to elaborate further?
Yeah, no, that's okay. I was told that I'd probably need to take it for about 10 years. So is that not right? Because I've had everything. I've only got a cervix left. That's all I've had.
Sure. I would be hesitant to give for 10 years. Okay. I don't know why that was thought. It's best to go back to a gynecologist and raise the query that why was I told to take 10 years? Usually, if I do something like that, I would prefer to have a chat with my patient at the age of 50 about weaning them off or stopping them.
Okay, that's good news. Thank you.
Yeah.
All right. So Michelle Winters has posted a question. Differences between endometriosis and adenomyosis. The pain, when does this end?
Okay. So good news, both of them end when menopause is achieved because there is no hormone. Okay. So that's the other good things about menopause, like you are less worried about having monthly bleeding, pain, and discomfort during the menstrual period. So endometriosis, so all over world, all the gynecologists, we don't know why endometriosis happens. These are the hypotheses. Okay. The most accepted hypothesis is that when the monthly bleeding happens, the inner lining gets washed off through the vagina outside. But sometimes some of the blood runs off from the tubes and falls inside the abdomen. Okay. And when it falls inside the abdomen, those inner lining cells, they hang on to the tissues where they have fallen and they start reacting to the hormones which are produced by the ovaries. So they undergo the whole changes like growth, and then during the ovulation and after the ovulation and during the menses, they bleed. And when they bleed, then they undergo fibrosis and a scarring formation, and that whole thing causes discomfort and pain. So that is endometriosis. Outside, bleeding outside, like the inner lining, like endometrial-like cells inside the abdomen is called as endometriosis. So what happens in adenomyosis? The same inner lining goes into the wall of the uterus, okay? And then those inner lining cells, they start reacting through the hormones and then cause same thing, like, they grow, they bleed inside the wall of the uterus, causes pain and more bleeding during the period. So that is the difference between adenomyosis and endometriosis. And they both stop once you hit the menopause because there are no hormones inside your body.
Thank you,
Did
Dr.
I answer
Vaishali.
that question? You're happy with that answer?
I don't see Michelle on here.
Yes.
Yeah.
Good.
I asked that question because there's it's just, I think health in general for women and research in health, it's not picked up early enough or taught early enough either through health education. And then I found a lot of women misdiagnosed as being depressed for no goddamn reason, and yet it was all related to the menopause. So there's a lot of misdiagnoses from GPs, and then there's their pain management. Some people can't have hysterectomies and have to put up with it all, and that's an issue.
Sure. Yeah. No, you just said what we are trying to address.
Yeah.
And your later part of your statement, what you said about endometriosis and pain, we have tried addressing that in our previous webinar. So if you could go and try to listen to that, we have tried addressing those things. And of course, if you have any question, please feel free to send an email to Pooja and she can forward those to me and I can answer how much I can.
Oh no, it's just because for Aboriginal women and their families, this information is not getting down. It's not like the health promotion and key messaging.
Yeah.
And research, there's a mislink between women and research and
Yeah.
health promotion and early intervention so it's just for the wider community. So
Yeah,
Yeah.
I agree. And the mistrust in the medical system for First Nation people, that stops them first to acknowledge and come to us and talk about it. I hear you, Michelle. I do. But
And
go on.
they don't like seeing the men GPs, and there's not enough female GPs, and then they go without, and then they rely on the hospitals, and then there's a whole range.
Yeah.
I'm sorry for intervening, but I think we're nearing the close of the session, and I think there are still a few questions to address regarding the topic that we covered today. So, Dr. Vaishali, if you don't mind, sorry about that, Michelle, and I think you could probably have an offline chat with Dr. Vaishali. We can definitely facilitate that if
she
you'd
answered
like.
my questions quite good. Thank you.
All right. So the next question is, does the frequency of periods increase like once in 23 to 25 days in perimenopausal period? Age 43.
Yeah. So, I'll answer that question. Before you go away, Michelle, our presentation, I think, are open to for your Aboriginal population as well. They can access our presentation, and you can send them to your Aboriginal community and your staff. And in future also, we are intending to do more webinars. We should be freely available for everybody. So you can get there. Now, coming back to this question.
Thank you. Thank you.
Coming back to this question, we have talked about perimenopausal having delayed period. But in some women, when the amount of egg starts going down, sometimes they do have more frequent period. Okay, but the number of such people are very, very small. Okay, but their periods are still light. Okay, they last less duration. Okay, so because as I was saying that it's not just one egg which tells the menstrual cycle or a uterus how to behave. It's the cohort of eggs which are producing the hormone usually affect or influence the duration of menstrual cycle. So when there are less number of eggs, there is less amount of estrogen. So the ovulation starts happening a little bit sooner than 14 days. Okay. And then the cycle starts getting smaller. But these cycles, as I said, they're shorter and they're lighter. So if you're getting frequent periods, and if you're worried and if you're premenopausal, it's best to get it checked out with your GPs and undergo a scan. There is no need of hormonal testing, but just get a scan done to see how your inner lining is.
Dr. Vaishali, we can probably take one or two more questions, and then I think we'll probably have to wrap up today's session. When a woman sees a GP about perimenopausal symptoms and they do blood tests, what are they checking, and what ranges would indicate that they are in or not perimenopausal?
So they check the hormone which is produced by the brain, because if the estrogen is less, then brain keeps on telling, hey, ovary, what happens? Since then, the brain is saying that, oh, work more, I want estrogen. So your FSH goes up. Okay, so we look at the cutoff of 40 of FSH. Okay, so cutoff of 40 is definitely menopause.
All right. That's a clear answer. Okay, if you do not know when your mother or maternal aunties went through menopause, what are some early indicators of perimenopause?
So irregularity of the period. Okay, having less period, lighter period, and shorter duration period, and sometimes some hot flushes. I would say just that. Or if you can, along with that, you might feel a little bit of discomfort while having sex, or maybe you need to have more lube while having sex. These can be the indicators of menopause. You don't need to undergo investigation. It's okay not to know. Like if mother and aunt had hysterectomy for other reason, how would you know? Right? So it's not a disaster. You can still, your body will tell you.
All right. Wonderful. So thank you so much, Dr. Vaishali, for answering all of those questions. And thank you so much to everyone in the session today for your active participation and involvement and interest in the topic. If you'd like to learn more about the women's health services that DPV Health can offer and can support you with, please visit the DPV Health website. And under the medical section on the website, you will find a page dedicated to women's health services. You can book an appointment with our Women's Health Clinic online on the DPV Health website, or by calling 1300-234-263 and selecting option 1 for medical services. Dr. Vaishali is available for any specialist consultations that anyone may be looking for, or we have other GPs who have an interest in the area and will be able to support women in the community. So again, once again, thank you so much for joining us today. Like I mentioned at the start of the presentation, today's session will be made available on the DPV Health website for anyone who wants to refer to it, or if you want to share it with your networks. But we hope to be able to bring these kind of sessions to the community again very soon in the future. Thank you so much.
I would like
Thank
just
you.
to add, Pooja, we have these things on YouTube as well, isn't it?
We have them on the DPV Health YouTube page as well.
Good.
Yes.
Yeah. Thank you, everybody. That was awesome.
Thank you very much. This is
Thank you, everyone.